Now we'll go on to the next talk is by our guest talk, and it's a keynote address by Dr. Tamer ELRAGGAL. He's from Egypt. Dr. Tamer is a professor of ophthalmology in Shams University of Cornea and Refractive Surgery. He's also consultant to Watani Eye Hospital. He's an elected board member of EOS, and he's also a board member of DEOS, board member of ESOIRS. So he's a very well-known ophthalmologist in Egypt and internationally also. And today we are going to hear from him, and he's going to talk on cataract procedure with previous refractive surgery. So Dr. Tamer ELRAGGAL.
Thank you very much, Mr. Chairman, Mr. Co-Chairman, and I'm very glad to be with you in this prestigious conference. I'm going to talk today about the cataract surgery with previous refractive surgery. As we all know, the refractive surgery is either corneal or lenticular. And the LASIK was FDA approved in 1998. This means it's now 27 years ago. So we have large number of patients currently ready for cataract surgery will be in the coming years. The concern in the post-LASIK eyes or post-corneal refractive surgery eyes is the high expectation of the patients, difficulty in IOL calculation, IOL selection for these patients, and the visual quality post-operatively, and the ocular surface problems in the previous refractive surgery. So, our patients having early refractive surgery are seeking early cataract surgery because they need perfect vision, demanding refractive cataract result as LASIK. So they are needing spectacle independence and asking for the latest IOLs to get rid of all glasses. They accept enhancement because they are very brave, and you have to set realistic expectations for these patients. The second most important difficulty is the IOL calculation. And the error in the IOL calculation is related to the instruments we are using, the formula we are using, and the refractive error index. We have many methods for calculation, and we have the problem mainly related to the previous corneal refractive surgery, related to the K reading, which is not the true K reading, and the effective lens position, which is the distance between the anterior surface of the cornea and the intraocular lens. We have many formulas used for these post-refractive surgery eyes, but the easiest method is to use the ASCRS calculator, which is free of charge. You can go through the website and you can enter the patient data regarding the corneal power and the axial length, anterior chamber depth, everything. If you have the history before the corneal refractive surgery, which is not the usual case, you can add. And at the end, you can get formulas that can be used in your IOL master, whatever the machine you are using. You can use the formula anterior segment OCT or Higgins L, Barrett through K, and Muscat. These are the most useful formulas or the most accurate formulas in post-corneal refractive surgery eyes. And you can take the mean value of these formulas, and if you have a wide range, choose the highest IOL power. Also, we have now the European Society Cataract Refractive Surgeon calculator. Again, it's free of charge. The IOL selection, according to the previous refractive surgery, you have to do a pentacam or topography to know the previous refractive surgery, either myopic, astigmatic, or hyperopic. And if you have myopic LASIK before, that means that you have an oblate cornea, and an oblate cornea with positive spherical aberration, you have to implant a negative spherical aberration IOL or negative aspheric IOL. For hyperopic LASIK, the opposite, we have a prolate cornea, or hyperprolate cornea, and you have to implant spherical or zero sphericity IOL. And these are example of the IOLs in the market. I have no financial interest. We can implant toric IOL, but provided you have a regular corneal astigmatism. And you can see this in this picture. If you have this patient with LASIK surgery or previous corneal refractive surgery, and you have central 3 millimeter regular astigmatism, you can implant. Although the appearance of the cornea is irregular, but still in the central 3 millimeter, it's more or less regular. You can implant a toric IOL. Never to do laser limb relaxing incisions, because the preoperative assessment of the corneal astigmatism is less reliable than inversion eyes. What about the multifocal or extended depth of focus IOLs? Multifocal is not preferable, but extended depth of focus of IOLs can be used in myopic LASIK, provided that you have a well-centered ablation, large optical zone, regular corneal astigmatism, pupil size is not that large scotopic pupil size, small angle kappa, and healthy ocular surface. And at the end, you can have an increased risk of dysphotopsias and higher order aberrations. But never place a multifocal intraocular lens in a patient with hyperopic LASIK, because this is a hyperopic LASIK or multifocal cornea. So multifocality in the cornea and of the lens can disaster the visual quality. Monovision is still a viable option in these patients. What about the post-operative visual quality if the patient is not satisfied? If you have irregular corneal astigmatism after surgery, after the phacoemulsification, due to decentered ablation or smoked optical zone, this is before the surgery, you can do two-step procedure. Number one, to enlarge the optical zone, or to centrate or center the laser ablation, and then after 3 months you can do more reliable IOL calculation. So you have to correct the corneal issue first and then do phacoemulsification afterwards. Many patients of the previous refractive surgery having OSD or ocular surface dysfunction, and this is very common after corneal refractive surgery. So we have unstable tear film with inaccurate K readings, and IOL calculation will be inaccurate also. So you have to optimize the ocular surface first. You have to treat the ocular surface dysfunction, and then you can have an accurate measurement of the IOL and accurate measurement of the refraction post-operative, and more smooth recovery and more wound healing properties. We can use combination of artificial tears. We can use lid scrubs, nutritional supplements, and sometimes IPL or thermal pulsations. The surgical technique is not that different from version eye, but you have to avoid the flap edge, so you have to have more posterior and more short tunnel, corneal tunnel. Take care, you are dealing with ametropic eyes, so you can have a deep or shallow anterior chamber according to the refractive state of this eye preoperatively. Intraoperative aberrometry, I don't have an experience, but it's not now popular at the time being. Post-operatively, you have to have more frequent follow-up visits. For fear of DLK, you can use steroids hourly, and then you have the usual tapering regimen. If you need enhancement post-operatively, you have to wait at least 2 to 3 months for stable refraction, and you have not to use topography-guided enhancement if you have toric IOL or sulcus-fixated IOL, so you can induce some lenticular astigmatism. But you can use the wavefront optimized or even wavefront-guided ablation for these patients. For radial keratotomy, now it's not that popular, but the surgical technique, you have to go with minimal size incision, and not to encroach on the RK incision in between. If you have 16, you don't have the way to go through outside the incisions. If you have insufficient space, you can use clearer tunnel. And if the RK incisions are crossed, you can make 2 horizontal sutures with low flow phaco, and you have to aim for slight myopia, because these patients having a hyperopic shift post-operatively. And sometimes the IC8 or the pinhole IOLs may be used in these cases. For the phakic IOLs, you have to use the formula for phakic eyes, not for the pseudophakic eyes, which is more accurate in these patients. You have to make sure that the endothelial count is good for the surgery, for the removal of the IOL, especially the anterior chamber IOL, because we have endothelial compromise for the long-standing IOLs in the anterior chamber, and during the surgery you are going to damage more endothelial cells, so make sure that the endothelium is healthy. If not, you can go for DMEC surgery with the cataract or the cataract surgery. If you have ICL explanted, you can do the phaco through the same incision because it's foldable, as you all know. In case of anterior chamber phakic IOL, rigid or PMMA, you can explant the IOL through a scleral tunnel, superior scleral tunnel, and you can do the phaco through temporal incision. Laser enhancement might be required in these cases. To conclude, a vast majority of patients with previous refractive surgery are ready for cataract surgery nowadays. Multiple formulas developed to compensate for alterations in the corneal power, including the OCT and the Higgins L, Barrett through K, Mascot. Consider the best IOL option for each patient. The ocular surface dysfunction must be optimized before surgery, and patients must understand the possibility of refractive surprise and anticipate the need of enhancement. And thank you very much for your attention.
Thank you very much, Dr. Tamer, for a wonderful presentation of post-LASIK cataract surgery, because you have explained each and everything, the IOL formula calculation and pre-op investigations and then the surgical procedure in all these cases. Because the most important thing what we see in post-refractive surgery, you should know that what refractive surgery was done. And if you have a history and if you have a record, then it becomes a little easier. If not, then you have to do a good pre-operative evaluation of the patient, which is very important in terms of pentacam, looking all the parameters of the eye, and then comes the IOL power calculation.